Hello, welcome back. Adam Rosen here. Today I am going to do my best to answer the question that many people have, and that is, do I need a knee replacement? Because it's a difficult decision for everybody to make. So in this video, I'm going to share with you all of the information that I share with my patients to help them answer that important question about when and if they need a knee replacement. So the first thing that I let patients know is that nobody really needs a knee replacement. If you fell and you broke your ankle and the bone was sticking out of your skin, you need surgery. I would tell that patient, you need to let me take you to the operating room to wash out the injury and put the bones back together. But nobody ever really needs a knee replacement. Arthritis is not a terminal disease, but it can negatively affect your health, both physically and mentally. Some people choose to use a cane and to limit their activity and to take medicines or have injections of cortisone. They do not want a knee replacement, but many patients that have severe arthritis choose to have a knee replacement because their arthritis is significantly affecting their life and they want to see the benefits of that surgery, which would allow them a better quality of life with less pain and better function. So this next thing might seem obvious to many people, but you should have arthritis on your x-ray. And not just mild arthritis, but you should have moderate to severe, or in many cases, severe arthritis. This is not to say that if you have mild arthritis on x-rays, that you do not have pain. I have this discussion with many patients that have pain, but have mild arthritis. And those patients, although they have pain, may not have severe enough pain to see the benefits that most people get from total knee replacement surgery. And there have even been studies that have looked at this and have found that patients that have more than 2 millimeters of space remaining on their x-ray have some of the worst outcomes after total knee replacement surgery. This next thing I'll share with you, I've also shared in my book, the knee book, and I share it with many patients, and it kind of fits with the arthritis picture on the x-ray, but it's a scoring system or a grading scale. So what I tell people is that if a normal knee was a perfect 10 out of 10, a really good or great total knee replacement usually is at best an 8 out of 10. We can't give you back your normal knee. Now I have some people that would describe themselves as a 9 out of 10 knee replacement, or even people that say their knee feels better than it ever did and they describe it as a 10 out of 10. But that's not the norm. And if you, on this scale that I've made up, would be a 7 out of 10, it's really hard to believe that after you go through surgery and 3 months of rehabilitation, that moving up 1 point on that scale is going to make you happy. The thing that we hate to hear, and I see this in some second opinions, are patients that tell me that their knee replacement knee now hurts worse than their knee did before surgery, and they wish they never had the surgery done. Because if someone has severe arthritis on x-ray and significant symptoms, and they're a 4 out of 10 on that scale, and they go from a 4 to an 8, that's 100% improvement. So in the right patients, you can see a huge benefit, but you don't want to rush into knee replacement surgery when you only have mild symptoms. It's also important before you think about going through a knee replacement, which is an invasive surgery, to try conservative things first. Simple things like oral medications, over-the-counter anti-inflammatories, or acetaminophen, or occasionally prescription medications for pain can relieve symptoms and allow you to improve your quality of life. Some patients even choose to try injections, and injections can be helpful and again offer temporary relief. The other important thing to work on in certain people is weight loss. I've had a number of patients over the years that were overweight and had mild arthritis on x-ray, but severe symptoms. And with weight loss alone, they have gotten rid of the severe pain and have improved their quality of life, basically pushing the need for knee replacement down the road. And the other thing that you need to do is modify your activity. Here in Southern California, I've had people come in asking for knee replacement that are surfing 7 days a week. I can't make a knee replacement patient surf more than 7 days a week. So it's hard for me to make that person's life or quality of life better. Same thing with tennis. If you have someone that's playing tennis 7 days a week, it's really hard to expect that a surgery is going to make their quality of life better. It might improve their pain, but many people should make changes or modifications in their activity, and they may be able to delay the need for a surgery such as knee replacement, and at that point also see the benefits and be happy with the outcome. I cannot stress the importance of strengthening more. Strengthening either on your own through what we call a home exercise program or informal physical therapy is extremely important, because studies have shown that people that have weak thigh muscles, the quadriceps muscles, whether or not they have a normal knee, an arthritic knee, or a total knee, can have pain in the knee. So if you're weak, strengthening the muscle and strengthening it alone may improve the pain, even in an arthritic knee. And again, delay the need for knee replacement. And there's no downside, because even if it doesn't help the pain significantly, the more strength you have coming into surgery, the better recovery that you're going to have after surgery. And the other thing that I use that strengthening program, and I have these patients do this straight leg raise exercise, usually 3 days a week, is if they can't find the time to do one exercise 3 days a week, it's really hard to believe that they're going to find the time to do multiple exercises multiple times a day, 7 days a week, which is important and necessary to get a good outcome after a total knee replacement surgery. Now, these next few things are things that many of my patients have seen that have helped them make the decision to go ahead with knee replacement surgery. So night pain, pain that wakes you up from sleep, pain even at rest. These are issues that are due to severe arthritis of the knee. Also, pain that is unpredictable, pain that comes and goes, and it can be very hard to plan your day because you don't know if today's going to be a good day or bad day. It's even hard to plan a vacation because you don't know when you're going to have an arthritic flare, and patients at times have had to cancel trips that they had been looking forward to for many months. Patients tell me I can't go walking with my spouse or my friends anymore, so they lose out not only on the exercise, but the social interaction with others. And patients have even had to juggle their normal daily activities, what we call your ADLs, or activities of daily living. They say, I can't go food shopping today because I have to walk the dog. I can't go to more than one big box store because I won't be able to walk if I go to 2 stores on the same day. And when people are dealing with that on a regular basis, it's a pretty clear indication that they're going to see the benefits from a knee replacement surgery. Now, this discussion would not be complete without the discussion of age. It used to be that we would tell patients, wait till you're older. And it was because implants were not very good, or we didn't know how long they were going to last. And nowadays, age is not a factor. So many young patients benefit from having knee replacement surgery as opposed to waiting for a number of years to hit some magical age. Most knee implants at 20 years, 90% of them are still functioning just fine. So there's a good chance that you might have a knee that could last a lifetime. If we're having this discussion of age, because this comes up, patients say, well, I don't want to be too old. Many of the times, if you're in the office with a surgeon having the discussion of knee replacement, you're usually going to make that decision in the next year or two. You're not going to be significantly older. But we did that study because we actually had a number of patients that were in their 90s. And we looked at patients in their 70s, patients in their 80s, and patients in their 90s. And the medical complications in patients in the 70s and 80s were identical. When you're 90 or above, the medical complication rate does go up. So for most of my patients, unless they're 89 years old, age is not a factor that would result in a greater complication rate. So don't worry so much about being too old or too young. If your pain and symptoms are severe enough and your quality of life is affected enough, and you do have arthritis that is severe on x-ray, consider knee replacement surgery to improve your life and reduce your pain. Now, many of my patients wonder, can they wait too long? Is there a risk of waiting too long before they decide to have surgery? And in certain cases, yes. If you need to use a cane or a walker, you're essentially disabled. Usually those patients are weaker, and it usually makes their recovery a little bit longer and harder because they have been weakened by using this assisted device because of their severe knee arthritis. If you stop walking completely and all exercise, the same rule applies. You're weaker, it's going to be harder to recover. And the other issue that we worry about is deformity. So in certain patients, if the pain is not severe enough where they choose to wait and then they develop a significant deformity where they're really knock-kneed or bow-legged, and you've damaged the bone or stretched out a ligament, we can still replace it. So patients wonder, if I wait too long, is there a chance where I get to where you say you can't do the surgery? And we can still do the surgery, but sometimes the outcome is a little compromised, meaning it's not as stable, or we have to use special implants to gain the alignment and stability that you wouldn't have had to deal with if we caught you early before that deformity set in. Now, the other common thing that many of my patients tell me is that all of their friends said, don't wait. Get it as soon as possible. I wish I didn't wait. I wish I got it sooner. And in some cases, that is true. If a patient had severe arthritis, they would have seen the benefits of the surgery, and in some cases wish they would have done it months sooner or even a year sooner. But you can't take that information to heart without understanding what your symptoms are. Because if you just started having mild knee pain and you only have mild arthritis and you haven't taken any medications or changed any activity, you do not want to rush into surgery for something that may be a problem down the road, even if you get severe arthritis. So if you have severe arthritis and pain and you've done the treatments that we've talked about, yes, consider surgery. Don't delay it till you're older or wait till you're on a cane. But don't rush into surgery at the first sign of knee pain, because it can be premature and your outcome may not be very good. The very last thing that I want to discuss with you is the idea of bilateral. Do you or should you do both knees at the same time? And it depends. Some surgeons do not do what we call bilateral knees. They will only do one at a time. Some patients only want one at a time. They're afraid of having both. Some patients prefer to do both because they only have one rehabilitation. It usually is harder if you do both at one time. And the complication rates are about the same. There's been a lot of studies that have looked at this, so it's hard to statistically say that one is safer than the other. But you should be optimized and you should be evaluated to make sure that you're safe to undergo both at the same time. But the most important thing that I want to talk to you about is you do not just get one done because the other one is being replaced. I tell my patients it's not like having your car on the lift and we tell you that we're changing the oil while it's up there. Would you like us to rotate your tires? This is a whole other surgery. And that second knee comes with all the same risks of the first knee: pain, infection, stiffness, instability, blood clots. So you don't want to do it just because you're having the other one done. I tell my patients, if they're considering doing both at the same time, is if we could cut you in half, like you were twins, mirror images, and you were sitting in two separate chairs in the exam room, would both of you be wanting a knee replacement? Because if you said the right knee was severe enough, but the left knee was really not that bad, then don't have both done at the same time. Because you might find that once the right is replaced, the left one doesn't hurt so much because the right becomes your good leg or your strong leg. So when you're considering doing both, make sure that both your right and your left knees have equally severe symptoms and equally severe arthritis to make sure that you get the best outcome out of both knees. Okay, well, if you've gotten this far in the video, thanks for watching. And if you enjoy this content, please like and subscribe so people like you find this video. I hope you found all this information very helpful. This is information that I discuss and share with my patients on a regular basis because it is a big decision. Having surgery is a big deal, especially a knee replacement. But if you've hit all of that criteria and you have severe symptoms and you have severe arthritis, then you're one of the lucky people that may see excellent improvements in both your pain, your function, and your quality of life after a surgery such as a knee replacement. Until next time, stay safe, and thanks for watching.